done 35 bedrocks. I've done all of them with navigation, but we did have a bit of a learning curve in our initial experience. That is due to be published in the Journal of Neurosurgery Spine. It's just been accepted, our first 21 cases. And that we do them all with navigation. And the key thing is the S2 alar iliac screw has to be just above the sciatic notch. And then you have room in the top of the teardrop to place an additional implant, whether it's a stack screw, triangular titanium rod, or any other device. But if you don't stay low and sort of parallel to the sciatic notch, then you will occlude the room for a second implant. And that can be done by very skilled surgeons with fluoro, but it is certainly more challenging. And I've only done it with navigation and then confirmed it with the 2D imaging. So it certainly can be done. You're absolutely correct that we don't have data yet, and that's the reason for the randomized controlled trial ongoing right now.
Yeah, David, some of the CT scans I've seen that you've presented, I just wondered about the capture on the very weak part of the dorsal sacrum as a fixation fusion that would be reliable. I know that you have good purchase in the ilium, just like you do with the S2AI screw, but it just seems like the sacrum is such a weak spot, especially there.
That's a great question, Jeff. And what I would tell you with our navigation, we reliably have about 40 millimeters of trajectory within the sacrum. And so the relative surface area that you're encountering is 30 to 60 millimeters, depending on anatomic variation and the particular surface of the implant. How much is enough? Great question. We don't know.
That's $100 million question, Dave.
Right. No, absolutely. And I completely acknowledge that. And that the other thing that I would say is that I've been doing S2 alar iliac screws for more than 10 years now. And we've just, we're reviewing our about 390 cases. And that when we see loosening, the loosening of the S2AI screws is not in the ilium, compared to, the old Lukey Galveston technique. The S2AI screws actually loosen in the sacrum. So as with a lateral to medial approach or almost any approach, the sacrum is always the weak point of fixation and weak point where we're most likely to see failure. And so how you solve that problem is really the challenge that we all face.
And especially, I do routinely the S2 alar ilium, and like I the patient, and especially in the elderly, where you do it, and it's more in the revision than in the primary cases, as we all have. This is always really a looking for the good bone. Most of the time not following the general rule of that screw, kind of adapting a little bit to find a good bone stock, but here, what I like about and why I would like to enter the study is the fact that you have two good one good screw first to have a base, and then you give you really have something to block in addition. So maybe fixation points should be enough, because the other problem is which we didn't talk about is those sacral fractures after those longer fusion, which we see in an increasing number, probably in the US as well. That's especially in those occult osteoporotics. You send them for a bone scan, which is rather -1 or something, not particularly dangerous. But then you're on the OR and you feel like a bit of cake or something. You try to put a bone screw in, and then therefore I think with those two trajectories, with kind of with this cortical bone in addition, not only twice but then 4 times, that might give you that additional little extra to base your corrective surgery on. At least that's what we have to show, but at least a good thought for me.
It seems like a biologic fusion versus counting on fixation to the weak bone in the sacrum. Seems more durable.
Yeah, let's see.
Dr. Pauly. This is Mo here. Recently, there was a publication by Dr. Islak from San Diego. He looked at the iliac screw versus S2AI, and he found out the chance of failure is more common with S2AI. Why? What is your thought about the cases that you put an iliac screw and then use a sacroiliac joint fusion and attach it to the proximal implantation?
So that's a great question, and it's the ICSJ retrospective look back that showed the 29% failure rate. And
Right.
that's counter to the literature meta-analysis that has shown that the failure rate in conventional iliac screws is higher than S2AI. So I don't know that I understand the exact reason why they found a different finding. I know that my revision rate in my own iliac screws when I was doing conventional iliac screws was probably on the order of 35%. My S2AI screws have not been that high. They're not perfect, but they're not, and usually it was the prominence of the iliac screw that was the problem. And I like the S2AI screw in part because I don't have to dissect out so far into the lateral recess and try to put the connectors in. And so I know Larry Lenke has modified that trajectory a little bit and is able to line the rod up. But I just find the S2AI screws to be more reliable in my hands. And I can't explain the ESLAC study findings to you at this point.
But do you use the navigation to put your S2AI or use fluoro?
I use navigation, and our typical screw size is 9.5 by 100, and that Cal Kabesh and Paul Sponseller have reported that if you're shorter, you're 80 millimeters or less, and less than 8 millimeters in diameter, there's a higher rate of failure of those screws.
Yeah, but
Thank you.
I mean, this is something very important to mention, right? If you use the with the navigation, it's always easy, you know, to put an S2AI screw versus an iliac screw, which is, you know, with conventional through probably easier. And the most important thing, I would agree, is that you have to have a proper length of the screw, at least 80. Otherwise, you know, your portion of being in the ilium is too short.
Okay, I think we have to stop here.